This conference will now be recorded.
So today we are going to discuss this July 2020 talk, which is about gynecological melanoma. This talk mostly discusses about different types of melanoma which are observed in gynecological practice, but focuses more on vulval melanomas because these are the most common things. So it will discuss regarding its incidence, staging, and treatment part of this, focusing more on vulval melanomas. So this malignant melanomas, these are derived from melanocytes. It accounts for 1% of all cancers. And of these melanomas, cutaneous melanomas is the most common things. Okay. So this melanomas, it mostly affects keratinizing squamous cell epithelium of sun exposed skin. So it is the cutaneous melanomas. The incidence rate, age standardized, it is 2.8 to 3.1 per lakh. But it differs in different ethnicities. So incidence is higher in white population, while the incidence is lower in black population. So 1.75 per 1 lakh people in Africa compared to 59.6 per 1 lakh in Australia. Cutaneous melanomas, they are detected at an early stage because they are clearly visible. So they can be treated early, so it will related to its good prognosis overall. Well, rarer type of melanoma, it is mucosal melanoma. So it can occur anywhere where the mucous membrane is there, like upper digestive tract, sinuses, conjunctiva, anorectum, and urogenital tract, which includes cervical, vaginal, ovarian, and vulval melanomas. So the annual incidence of mucosal melanomas, it is stable throughout the population, and it is 2.8 in 1 million women, while 1.5 in 1 million males. So it represents total 0.03% of all cancers. And of this, vulval melanomas, these are more common. It constitutes around 76.7% of all gynecological melanomas. Okay, so vulval melanomas, they constitute 76.7% of all gynecological melanomas. Now we will discuss individually regarding each gynecological melanoma. So ovarian melanoma, it is the rarest one. Most cases are thought to be metastasis rather than the primary ovarian melanoma. Average age of presentation is around 53.7 years. Symptoms are abdominal pain and distension, similar to other ovarian cancers. But usually the women have metastatic disease at the time of presentation. Most women, these are treated with surgery, that is PAH, BSO, and omentectomy. Some women, they receive adjuvant therapy with carboplatin chemotherapy or interferon. But this primary ovarian melanomas, these have very poor prognosis. So only 50% of stage 1 melanomas, they live at 2 years compared to 89% of squamous cell carcinomas. Okay, so this ovarian melanoma carry very poor prognosis. The next thing is cervical melanoma. These are also rare. And the woman who present with the cervical melanoma, the age is postmenopausal age group, symptoms having irregular vaginal bleeding, postcoital bleeding, and dyspareunia. Signs, when you do the speculum examination, it is a pigmented ulcerated mass which is seen from the cervix. So this sign is present in around 50% of women. Diagnosis is usually by speculum examination and biopsy of that mass. Cervix is uncommon site of metastasis. So it might be most commonly these are the primary melanomas, but you have to rule out any metastatic melanoma. So for that, you have to do CT scan of chest, abdomen, pelvis, and brain before considering it as a primary melanoma. Okay. So what are the diagnostic criteria to decide it as a primary cervical melanoma? So the presence of melanin in normal cervical epithelium, the absence of melanoma anywhere else in the body. So these are the two things which determine that this melanoma is a primary cervical origin. Also the demonstration of junctional changes in the cervix and metastasis according to the pattern of cervical cancer. So the metastasis in cervical melanoma, it has a tendency to spread in areas like vagina, uterosacral ligaments, uterus, and pelvic side walls. So it spreads like a cervical cancer, okay? It spreads like cervical carcinoma rather than a hematological spread of melanoma. See, melanoma usually spread by hematologous route, while the cervical cancers, they spread through lymph nodes. But here the primary cervical melanoma, it also spreads like that of a primary cervical cancer. Okay. So in cervical melanoma, the staging system used to stage the cervical melanoma is a routine FIGO staging for cervical cancers rather than HSCC staging of melanoma. So remember, this can be also asked as a question. So for cervical cancers, you are going to use FIGO staging for this routine cervical cancers for staging melanoma. While other elsewhere in this genital tract, you are using staging system that is known as HSCC staging system for melanoma, which is used for cutaneous melanomas also. Management of cervical melanoma. So there is no clear consensus because this is rare. Usually, if the woman is diagnosed in early stage, it is like a radical surgery, like the radical surgery we do for early stages of cervical cancer, that is radical hysterectomy. And for advanced cancer, there is no, advanced melanoma, there is no effective regimen where you can use adjuvant treatments. But the adjuvant treatments which are used for melanomas, cutaneous melanomas or other mucosal melanomas, that can be used for this palliative options. Prognosis is poor, only 10.7% have 5-year survival rate. Okay. So 5-year survival rate for the cervical melanoma is only 10.7%. Vaginal melanoma, it is also rare, but it is more common than that of a cervical. So it constitutes around 0.3% of melanomas. Average age of diagnosis is 60 years. It most commonly occurs in lower third of vagina, and it is seen as an irregularly shaped, darkly pigmented lesion. Symptoms is irregular vaginal bleeding, which is the most common symptom, pain, vaginal discharge, and palpable vaginal mass. In 20% of cases, these vaginal melanomas, these are multifocal. Diagnosis of primary melanoma or primary vaginal melanoma, it is made when the primary site is vagina and disease tends to spread towards the cervix. But in more advanced disease, primary site is difficult to identify. So for vaginal melanomas, staging uses HSCC staging. Management of vaginal melanoma, it is the surgery with wide local excision. So excision margin are recommended as nice cutaneous melanoma guidelines. So it is for stage 1, 10 mm and for stage 2, 20 mm or 2 centimeter. Women who are undergoing surgery, they are found to have better survival because see, most commonly the patients who went for surgery, they have an early stage disease. Okay, they have a more favorable stage who undergo the surgery. If the wide local excision with appropriate margins is not possible, then you can go for extensive surgery. So where this wide excision is not possible, then you have to go for this exentration, that is anterior, posterior or total exentration, pelvic exentration. The 2014, this consensus group, gynecological cancer intergroup consensus, they advised against lymphadenectomy for vaginal melanoma unless there is lymph node metastasis. So primary lymphadenectomy should not be performed for vaginal melanomas unless the lymph nodes are involved. Radiotherapy can be used to shrink the tumor. If the disease is spread widely, radiotherapy can be used to shrink the tumor, but it has a limited success and it is used only in palliative settings. Another options which are used is imiquimod 5% topical use. It is also as effective as adjuvant treatment, but it is a very short, very small number of patients are involved in the trial. Also targeted therapies which we will discuss later, that can be also used. The woman with positive lymph nodes, they have a lower median survival. So it is only 7.8% where the lymph nodes are involved. Okay, while negative lymph nodes, it is a so where the lymph nodes is involved, the median survival is only 7.8 months, while the lymph nodes are not involved, median survival is around 30 months. So up to 40% women, they have local recurrences and poor 5-year survival, which is only 0 to 20% for vaginal melanomas. Then vulval melanomas, these are the mucosal melanomas or vulva, and these are the most common genital tract melanoma. It represents 76.7% of cases, but still they are very rare. So incidence is 0.1 per 1 lakh. They have much poor prognosis, that is 15% of 5-year survival. Again, here it is the vaginal melanomas. They are totally different from this vaginal squamous cell carcinomas in the case of biology, presentation, and pattern of spread. The median age of diagnosis is 68 years, and more than 90% they occur in white women. Risk factors for vulval melanoma are HIV, other viral infections, chronic inflammatory conditions, and chemical irritants. Genetic mutations which are responsible for melanoma. So there are two types of genetic mutation. This is c-KIT mutation and BRCA mutation. So BRCA mutation, which is V600E, it occurs in usually 50% of cutaneous melanomas. So this BRCA mutation is specific for cutaneous melanomas, while c-KIT mutation, it is associated with mucosal melanomas. Also, c-KIT mutation is associated with testicular seminomas and AML. So c-KIT mutation, they are found in 33% cases of vulval mucosal melanomas. So remember, these mutations which is associated with vulval melanomas is c-KIT. So initial presentation, so patient will present with symptoms of itching, bleeding, discomfort, or urinary symptoms. There will be usually a pigmented lesion or sometimes enlarged groin lymph nodes. The most common site is clitoris, then followed by labia majora, then labia minora, and periurethral area. While vaginal introitus is the least common location. So here you can see these two pictures. So this is a seborrheic keratosis, which is a defined thing, raised surface, discrete edges. So edges are more defined and consistent color. Color is throughout uniform. While this is vaginal melanoma, here you can see it is a smooth surface, edges are blurred, and it is multicolored. Investigations and staging. So first you have to assess the size, location, and skin changes. Also you have to see for the proximity to the urethra or anus, so for the orifices. Also speculum examination should be done to rule out any vaginal involvement or spread. Palpation of inguinal lymph node should be done. And here for the treatment, investigations and treatment part, there will be two MDT should be involved. So one is a gynecological oncology MDT and another is a melanoma MDT. So it should be a joint decision by gynecological oncology MDT and melanoma MDT. So for diagnosis, the biopsy which is preferred is small incision biopsy for vulval melanoma. So, and for vulval cancers, it is a excisional biopsy, correct? So it is incisional biopsy for vulval melanomas, or mapping biopsy if there are satellite or multiple lesions are there to guide full excision. Okay. If multiple biopsies are needed or there is concern of urethral or anal involvement, you should do sigmoidoscopy and cystoscopy and examination under anesthesia. Also, if the palpable groin nodes are there, you can do core biopsy or FNSC. Now, to rule out other metastatic disease, you have to see for systemic disease, that is CT thorax, abdomen, pelvis, also including groin, and MRI or CT brain. So, to see for more distant metastasis. Now, if the major surgery is planned, if the excision, wide local excision is not possible, if it requires exenteration, then you have to rule out metastasis of brain by doing either PET scan or MRI. Okay, to exclude low volume metastatic disease, because this metastatic diseases have poor prognosis and usually exenteration surgery is not performed in such cases. Okay. Then for vulval melanoma, again, you have to use this AJCC staging. So in this AJCC staging, they include thickness for Brislow classification for thickness, level is Clark level, ulceration and spread, but tumor size is not included. Melanoma subtypes. So for cutaneous melanoma, these are the 5 subtypes, that is lentigo maligna melanoma, superficial spreading melanoma, acral lentiginous melanoma, and nodular melanoma. While for mucosal melanoma, these are other melanomas, polypoid melanomas, and desmoplastic melanomas. I don't think this is very important for you. Just so melanoma fulvas, these are mucosal. Mucosal melanomas, this can be multifocal and they can be arise de novo rather than from a nevus. Okay, so cutaneous melanomas, they are usually arise from nevus, while vulval melanoma, they arise de novo, so without any predisposing lesion. Superficial spreading melanoma, it is the most common cutaneous melanoma, but it is not common in the vulva because this is not exposed to sunlight. So when you are discussing, when you are doing the staging or doing the biopsy, the pathology report, it should include tumor size, tumor depth, ulceration status, cytomorphological subtype, lymphovascular and perineural invasion status. Also, you have to see which neighboring structures are involved and whether the resection margins are involved or they are free. So it should be aided by immunohistochemistry, and the markers which are used are protein S100, melan A, and HMB45 and vimentin. So these are the markers which are used for this pathological grading or involvement of the margin. Also, the lesion should be commented regarding inflammatory changes, pigmentation, and necrosis. And involvement of lymph node and metastasis, it should be recorded. Also, molecular testing should be done for this BRAF and c-KIT mutation because sometimes targeted therapies can be used in case of advanced disease. So this is HSS staging. I don't think it is very important for you. Just it is a routine TNM staging. Okay. So it is T for tumor size, N for nodal metastasis, and nodal involvement, and M for metastasis. So TX where the tumor size cannot be assessed. T0 no evidence. TIS is melanoma in situ. T1 less than 1 millimeter. T2 1 to 2 millimeter. T3 2 to 4, and T4 is more than 4 millimeter. So again, this is again classified into A and B. So A for without ulceration and B with ulceration. So tumor without ulceration is always it is T1, T2, whatever it is it is already classified again into A and B. Then nodal classification, when NX, when the nodal state cannot be assessed. N0, there means no lymph node metastasis. N1 to N3, depending upon the number of nodes. And again, it is subclassified into A and B, where there is micrometastasis or macrometastasis. And then metastasis or M, it is again M0, there will be node metastasis. M1A, it is metastasis to skin, subcutaneous and distant lymph nodes. M1B is metastasis to lung, and M1C is metastasis to all other visceral sites or distant metastasis, or whenever there is a LDH, elevated serum LDH, then it is always known as M1C, whatever may be the metastasis status. Now, surgical management is the mainstay of treatment for this vulval melanomas, but there is still uncertainty regarding the margin status. So how much it should be excised, there is still no consensus. So it can be either a wide local excision with 10 mm of margin, okay, 10 mm of margin when you are doing the surgery, or R0 status. So R0 status means when you are examining the specimen, the margin should be microscopically clear for more than 1 millimeter. So it is either it is R0 status or 10 millimeter margin is the required thing here. When the R0 status is used, it limits the morbidity and loss of function. Okay, so it avoids the major surgery. Nice cutaneous melanoma guidelines, they advise the surgical margin depending upon the bristle thickness. So 1 centimeter for stage 1 melanoma and 2 centimeters for stage 2 melanoma. For sentinel lymph node excision in vulval melanoma, evidence is still limited. But what the NICE guidelines for cutaneous melanoma, it advises that sentinel lymph node biopsy should be done when the bristle thickness is more than 1 millimeter. Okay, so you have to discuss the pros and cons of this sentinel lymph node biopsy with the woman, and if the lymph nodes are enlarged on clinical or imaging, then it is better to remove this lymph node. Then sometimes exenteration surgery is required, as I told you previously also. So if this exenteration surgery is required because of widely size of the tumor is more, then for this exenteration, you have to first rule out brain metastasis by doing PET scan or MRI. Then when the melanoma is surgically not resectable, then what are the adjuvant treatment options for this gynecological melanomas? So usually melanomas, these are considered resistant to the radiotherapy. But adjuvant radiotherapy, it has been used for cases where the closed or where there is involved surgical margin, or if they are unsuitable for further excision, like nearer to the anus or nearer to the urethra or orifices. It has also been used in primary setting if there is irresectable or metastatic disease for local control. Then for bone metastasis, you can use palliative radiotherapy, and for brain metastasis, you can use stereotactic radiotherapy. So this is the role of radiotherapy in case of melanoma. So it can be used for recurrent disease or irresectable disease, bone metastasis and brain metastasis. So this is the role of radiotherapy. The role of chemotherapy is very limited in case of melanomas. The only used agent is dacarbazine. It is an alkylating agent, but it has a very low response rate, around 15% only. Then newer therapy which are used is targeted therapies and immunomodulators. So targeted therapies, as I told you, cutaneous melanomas, they have this BRAF mutation, B600E. So these BRAF inhibitors can be used for this cutaneous melanomas or where this BRAF mutation is there. So BRAF inhibitors, this is the drug is bemirafen. So it can be used. The adverse effects with this bemirafen is arthralgia, rash, fatigue, alopecia, keratoacanthoma, or squamous cell carcinoma. And 38% patients require dose modifications because of toxicity. Then the patients who have the c-KIT mutation, there the drug used is imatinib. But still there are no randomized data to support any of this use. Then other therapy which is used is immunomodulators. So there are two agents which have been used. One is ipilimumab and another is nivolumab. So ipilimumab is a cytotoxic T lymphocyte associated antigen 4. Okay, so it blocks that one and it inhibits or downregulates this T cell inhibitory signals and induce antitumor response. Response rates, these are around, they're very low and around 10%, but it improves overall survival. And nivolumab, it is inhibits the programmed cell death protein and causes activation of T cells. So, but there are continuing trials with nivolumab is there. So these agents, immunomodulators, these are under trial for this melanoma treatment. Now, after the treatment, what is the follow-up for these melanomas? These are these mucous melanomas or gynecological melanomas. These have a high rate of recurrence or relapse, and this relapse are most common in first 3 years. The recommended follow-up schedule is first 3 years, 3 monthly assessment, followed by 6 monthly assessment to complete 5-year follow-up. So for first 3 years, the follow-up should be every 3 months, and then every 6 months for to complete the 5 years. So at each follow-up, there should be vulval inspection, palpation of inguinal lymph nodes, speculum examination, and examination under anesthesia or cystoscopy if it is clinically indicated. Also CT imaging if it is clinically indicated. Then personalized follow-up, it should be done for women who are at increased risk of primary melanomas, like atypical mole syndrome, previous melanoma, first degree relative with melanoma, or other relevant familial cancer syndrome. And in such patients, referral to genetic services, it should be also considered. So this is in short regarding this vulval melanoma, total gynecological melanomas. But I think for you, which is more important or question can come on this only in vulval melanomas. So thank you. Today it's the last slide. I think tomorrow we will meet with another one. Okay. So bye for now.
Thank you, ma'am.